Ladies and gentlemen, today's topic is on prevention of mother-to-child HIV transmission. We are going to look at the antenatal component of the program. These are some of the symbols that we would use as part of the presentation. In green is a phone, showing that we would like to collect more patient information. In the house in red reflects that the patient might need to be managed at different levels of the health system. The red phone refers to the urgent need to refer a patient, and lastly to reflect the linkages to care for pregnant women. PMTCT has 4 prongs. The first prong is about prevention of HIV in women who are living without HIV, and reflects the need for us to have targeted programs, prevention programs, and education programs to keep women HIV negative. The second prong reflects the need to improve access to family planning. And today we are going to focus on the third block, which is about women who are HIV positive and pregnant, who are in need of ART for their own wellness and also for the prophylaxis for children. And lastly, the care and support needed for women and their children. At the heart of the PMTCT program is the need for women who are pregnant to be diagnosed early and to book immediately as soon as the pregnancy is diagnosed. No mother should be turned away, and no one should be rebooked to come back for another day. All women who are diagnosed to be pregnant should be assessed and be registered as pregnant on the same day. For all HIV positive first antenatal visits, we expect proper history to be taken and a full examination to be done with an aim to assess maternal risk to ensure that by the end of the pregnancy, both the mother and the child are alive, healthy, and the child is without HIV and AIDS. The entry point to access ART services in pregnancy is HIV counseling and testing. This service should be provided during the first visit or during the booking visit. Ideally, we would prefer to also offer the test to partners and any existing children. And women should be managed by a multidisciplinary team, doctors, nurses, social workers, in an integrated approach. All women need to be counseled and they need to be offered an HIV test during their first visit. If the mom or woman tests negative, we usually conduct a retest during every subsequent visit. The old PMTCT guidelines would refer to 6 weekly retests, but the current basic antenatal care guidelines refer to the need for women to visit their clinics every month, and therefore the test should be provided at each and every visit, which means it is monthly. If a woman tests HIV positive, she needs to be prepared and to be initiated on ART same day. Remember, when women present for ANC, they first go through group counseling, then individual counseling. The test is provided. If the test is positive, we would then prepare the mom for initiation of triple drug therapy. If the test is negative, we would then offer repeat HIV test at every subsequent visit. Again, for HIV negative women, the aim is to keep women negative. They will be retested every month, and we prefer that their partners must be brought on board. If a woman also present in labor and she was negative earlier on, a test need to be reconsidered, and they need to be tested every 3 months during the postnatal period. Why we retest these women? Because we know a significant number of women would seroconvert during the antenatal or breastfeeding period, having high viral loads, which is a significant risk factor for transmission of HIV from mothers to their babies. So we have to try and find these mothers as soon as possible and initiate them on heart. But at the heart of it is to have programs, interventions, increasing access to condom and education, getting partner support to ensure that our women remain HIV negative. If the test is positive, we would then provide post-test counseling, conduct baseline blood tests, your CD4 cell count and creatinine. We would initiate ARVs same day, regardless of the CD4 count or gestational age. We do not wait for blood results to initiate, but we start triple drug therapy, TDF, emtricitabine, efavirenz same day. We draw the bloods and ask women to come back within 7 days to review their results. Women who are HIV positive need to be thoroughly counseled, probably requiring more than one visit, because it is a lot to take in the fact that they are pregnant and now they are HIV positive and they need to be taking treatment lifelong. And additional support from home is also usually needed. All HIV positive women should be managed as per the PMTCT program from the time when the pregnancy is diagnosed up to at least 1 year after delivery of the baby, of which they can then be discharged onto the adult program. As part of the clinical assessment and plan for HIV positive pregnant women, a clinical assessment should be done. We have to screen women for any active psychiatric illness, especially psychosis, urine dipsticks to assess kidney function, baseline bloods, creatinine and CD4 count, and a follow-up visit be scheduled within 7 days. All women, regardless of HIV status, should receive the basic antenatal care, and we should always remember that non-pregnancy related infections are a leading cause of maternal deaths in South Africa. Therefore, TB should be screened and be treated with vigilance, and other infections such as STIs need to be screened and treated accordingly. Where there's contraindications to starting ART same day, especially those who've got abnormal renal function, active psychiatric illness, and those with suspected or TB infection, AZT 300 milligrams BD should be started until triple drug therapy can be initiated. Okay. Where you suspect that there might be a renal dysfunction, especially in patients who are diabetic or hypertensive, those with previous kidney conditions, those with a high protein in urea, we would delay the start of a triple drug therapy. We would collect blood for creatinine and then initiate them on AZT 300 milligrams same day, as long as they are not anemic. As soon as the results are ready, or within 1 week, if the creatinine is normal, we would initiate a triple drug therapy containing TDF, FTC, and efavirenz. If the creatinine is above 85, this is a high-risk pregnancy, and these women should be referred to an obstetric high-risk clinic, and the AZT be continued until the issue is resolved. If you consult with your clinical mentor or the obstetrician, you are likely to be advised to initiate your patient on abacavir, 3TC, and efavirenz, since this is a renal-friendly regimen, so the patients can continue on this regimen until the kidney functions have been improved. Remember, if there's also proteinuria in the urine, we have to follow local protocols as per the standard treatment guidelines. This is an example of the results, comparison between your creatinine and your estimated glomerular filtration rate in pregnancy. Your EGFR tends to be a bit unreliable because the weight of the mom is exaggerated by her pregnancy. A creatinine above 85 is abnormal, and we wouldn't want to initiate a tenofovir based regimen. We would either start AZT 300 milligrams BD or a kidney-friendly regimen containing abacavir, lamivudine, and efavirenz. Remember, a high creatinine or renal function in pregnancy is a high-risk pregnancy, and these mothers would require to be referred. Where we suspect that there is an active psychiatric illness, especially psychosis, hallucinations, delusions, that is also a high risk pregnancy, we would provide AZT 300 milligrams BD at least until the psychosis is controlled. Most of the time, we need to offer an alternate regimen that is without efavirenz. So we would give tenofovir with lamivudine, then consider an option of a third drug between nevirapine and lopinavir ritonavir. Where nevirapine is used, the decision point is the CD4 count. So if a patient has a CD4 count less than 250 cells, we would then opt for nevirapine 200 milligrams daily for 2 weeks, which would be increased to a BD dose thereafter. If the CD4 count is above 250, we would then opt for lopinavir ritonavir as the third drug to complete the regimen to be a 3-drug regimen. We must remember to screen every woman regardless of HIV status for TB. If they do not have symptoms, which means the TB screening test is negative, we have to counsel them about the need for IPT. If this refers to HIV positive women who are pregnant, who are without TB symptoms. Where it's available, we have also to do a skin test. Okay, so HIV positive women with a negative TB screen are eligible for IPT with pyridoxine. The duration is either 12 months or 36 months, depending on the skin test result. Okay, so if the skin test is positive, we prefer 36 months IPT therapy. This reduces their TB risk to that of an HIV negative population, which is from 10% per year risk to 10% lifetime risk of acquiring TB. Where we have screened them for TB and we suspect that the mom might be having TB or the TB has been diagnosed, we prefer not to start triple drug therapy. We would start them with AZT 300 milligrams BD until the TB investigations have been concluded. If TB has been confirmed, the AZT would be continued for 2 weeks. And then after 2 weeks, when the patient now tolerates TB treatment, we would then stop the AZT and start FTC. So in summary, women who are TB suspects need to be investigated. If TB is confirmed, we start TB treatment. We continue the AZT 300 milligrams BD for 2 weeks. At 2 weeks, we review. If she's tolerating her TB treatment, we can then stop the AZT, then start a triple drug therapy, TDF, emtricitabine, and efavirenz. We must always prepare women that they might have some exaggerated inflammatory response, and should that happen, women need to present for care. They shouldn't stop treatment on their own. We need to follow them up very closely and to reassure them that IRIS means treatment is working. Half the time they just need supportive therapy to manage the inflammation, and they do well. We need to also record on the infant card that the mother had TB, because the child might need to be investigated for TB when they are born. Okay, if TB has been excluded, so we screen for TB, we suspected TB, but we have excluded that this was not TB, we would switch the mom from AZT to FDC, screen them for TB again in 1 month, and reconsider IPT prophylaxis from there. We do have adolescent pregnancies and teenage pregnancies. If you have a child, an adolescent with a weight more than 40 kilograms, they can be initiated on adult doses of TDF, emtricitabine, and efavirenz in a combined tablet. However, if the adolescent weight is less than 40 kgs, they can be initiated on TDF as a full dose, lamivudine as a full dose. However, the efavirenz dose needs to be reduced from 600 milligrams daily to 400 milligrams daily. We do not have a combination that contains efavirenz 400 milligrams daily, so we would give Truvada plus efavirenz capsules. These are the 200 milligram capsules, 2 of those at night. This group of patients are very difficult. It's adolescents, so they need to be supported. We need to make sure that our services are friendly for them. We have support groups, and they are able to be supported at home. If the weight of the adolescent is less than 35 kgs, Abacavir is probably the best NRTI to be used. So Dumiva, which is a combination of Abacavir, lamivudine plus efavirenz 400 milligrams, is likely to be our combination of choice. In our PMTCT journey, our goal is to suppress the viral load. It's all about the viral load. We know that if the viral load is suppressed, the risk of transmitting the HI virus to the child is almost zero or non-existent. When the viral loads are high, we have a significant risk factor that HIV will be transmitted to the child. So women presenting with HIV and who are pregnant, we have 2 groups. We have women who fall pregnant whilst already on ART. This group of women would require a viral load to be done at pregnancy diagnosis. If that viral load results come back and the results are high, we have to do intense adherence support for women, repeat it within 30 days. If you have 2 viral loads that are above 1,000 30 days apart in pregnancy, we consider that that pregnant mother might have failed first line ART and would require second line ART regimen. The second group of women is women who fall pregnant and they are newly diagnosed during the current pregnancy. They would then start ART, continue ART for 3 months, and during 3 months on ART, that's when we would do the first viral load. Okay, so women who fall pregnant whilst on ART, we would do a viral load on pregnancy diagnosis. Women who are newly diagnosed, we start hard, they continue for 3 months. At the 3 months period, that's when we do the first viral load. Okay, the goal is to suppress the viral load, preferably to be less than 1,000. The viral load would be done every 6 months antenatally. I'm personally of the opinion that it should be done at least every 3 months during the antenatal period. However, guidelines recommend 6 monthly viral loads. If the viral load is above 1,000, we suspect that the mom might be failing therapy. The viral load should be repeated in 1 month's time. During the 30 days between the two viral loads, we have to do intense adherence support, help mothers to take their treatment, get a secondary family member to support her when she's at home to ensure that she's taking the treatment. If there's any side effects, we manage the side effects. If we can simplify the regimen, we try to make it as simple as possible. At this point in time, because we have a high viral load, it's important that we do an HB if we think we are going to be giving her an AZT zidovudine based regimen. Hepatitis B surface antigen must be done because most women in South Africa are taking a combination of TDF, FTC, lamivudine or emtricitabine plus efavirenz. We must always remember that tenofovir together with emtricitabine or lamivudine, these two drugs are also very active against hepatitis B infection, and the co-infection rate between hepatitis B and HIV is quite high. So before we interrupt any regimen where TDF and lamivudine or emtricitabine are part of the regimen, we have to make sure that we have checked the hepatitis B surface antigen. If it is positive, when we switch to the to the second line regimen, the patient might need for a 4-drug ART regimen, TDF, emtricitabine, AZT, with lopinavir, ritonavir. So it's very important that we check hepatitis B surface antigen status. If we interrupt TDF and lamivudine or emtricitabine in patients who have hepatitis B, we might end up with a patient who's got a rebound hyperviremia coming in with deep jaundice, abdominal pains, and sometimes we might even lose the patient. Okay. So if the first viral load is above 1,000, we repeat it again in 30 days time, which is 1 month. If we've got 2 viral loads above 1,000, we have to consider whether there is some improvement or not. If we have a high viral load and we have failed to reduce the viral load by more than 1 log, probably the patient is failing therapy and should be considered for second line. However, if the viral load comes back to be suppressed or we had more than 1 log drop, we can still give our patient a chance for suppression. Again, before you switch to second line, check hepatitis B surface antigen. If it's positive, we would have to give TDF with lamivudine or emtricitabine and add 2 new drugs, zidovudine and lopinavir, ritonavir, on as part of our second line ART. Remember, if the mom has hepatitis B, the child would need to get hepatitis B immunoglobulins and also immunization at birth. So this is an example of your viral load results. You can see, from 5.6 to 3.9, there was at least 1 log drop. So there was some improvement within 30 days. In this instance, we can give the mom, some chance to continue on first line and probably repeat the viral load within 3 to 6 months. Okay. Again, this is 1 log drop, 5.9 to 4.3 improvement, very significant. 5.1 to 4.9, there is no improvement. This mother needs to be switched to second line. There is no improvement. This mother needs to be switched to second line. Okay. In terms of monitoring, stable mothers on ART will do a creatinine at baseline before we start ARVs at 3 months, 6 months, and then 12 months, then annually. CD4 count, baseline, and 12 months, never again. Remember, women with CD4 counts less than 200, stage 2, 3, and 4, which means HIV symptomatic pregnant women, must be given cotrimoxazole prophylaxis. And also women with CD4 counts less than 100, a cryptococcal latex antigen test should be done. If it is positive and they are asymptomatic for meningitis, they should get fluconazole prophylaxis therapy. If the latex antigen is positive and they have symptoms of meningitis like headaches and confusion, they need to be started immediately on fluconazole and 6 tablets, and then be 6 tablets of the 200 milligrams, and be referred urgently to the hospital for a lumbar puncture and further management. Okay. Women need to be supported throughout the pregnancy, after the pregnancy, and in between, their kids. PMTCT interventions only work if they are adhered to and when there is effective support. Remember, the drugs we provide in pregnancy are toxic, so we need to monitor the kidneys. That's why we have to do a creatinine level. If they are on AZT, we have to check their HBs. If they are on efavirenz, we need to monitor their liver and rash. Especially when they are on nevirapine, we have to really pay attention. Okay, thank you very much for your time. I hope there was something to learn from this presentation. There's a space for comments below this video. Do comment, add your views, let's discuss, but importantly, let us all commit to preventing HIV transmission from mothers to their kids. Remember, PMTCT is a 4-pronged strategy. The first prong is to ensure that women who are sexually active in their childbearing age remain HIV negative. The second prong is to ensure that all pregnancies are planned, women book early so that we can intervene early. The third element is to make sure that women who are pregnant and HIV positive are initiated on hard, they are kept well, and we make sure that their kids are born without this incurable disease, HIV. And the last prong is to ensure that we have care and support programs for mother-baby pairs. Thank you very much for your time. We look forward to hear from you. Thank you.